Hello, this is Dr. Philip May. I'll be speaking with you today about Fragile X syndrome. This is for primary care physicians. Fragile X syndrome is defined as a genetic neurodevelopmental disorder caused by a dysfunction of the FMR1 gene located at the XQ27.3 site band of the X chromosome from either the mother or father. It's characterized clinically by cognitive dysfunction, hypotonia, behavior problems, increased risk for seizures, hypogonadism, and a typical phenotypic appearance, especially large ears, elongated face, and macroorchidism in males. In 1943, Martin and Bell demonstrated a particular form of mental retardation which they showed was X-linked. They did not use the term Fragile X, but they did notice that this type of cognitive problem was related to the X chromosome. In 1969, Herbert Lubbs noted the relationship of mental disability with an unusual X chromosome, and he developed the chromosomal test for Fragile X. Lubbs did not use the term Fragile X, but it wasn't until 1970, a year later, that Frederick Hecht coined the term fragile site. Then it became known as Fragile X syndrome. In 1991, the FMR1 gene that causes Fragile X syndrome was identified, and in 2001, the initial cases of Fragile X-associated tremor ataxia syndrome and Fragile X-related primary ovarian insufficiency were first recognized. The physical features or phenotype include large protruding ears, a long face, a high arched palate, hyperextensible joints, flat feet, soft skin, and macroorchidism in men, which occurs after puberty, and also hypotonia. Fragile X syndrome is the most common inherited cause of mental deficiency. Of course, Down syndrome is also a genetic disorder, which is more common, but Down syndrome is rarely inherited. The syndrome of Fragile X occurs in approximately 1 in 3,600 males and 1 in 4,000 to 6,000 females. However, approximately 1 in 250 females and 1 in 800 males carry the Fragile X premutation and thus would be considered carriers. So the carrier state is pretty common. Just to review the normal chromosome analysis or karyotype, just to refresh your memory, since we are primary care physicians, we're not geneticists. There are 22 pairs of autosomes and 1 pair of sex chromosomes, giving you a total of 46 chromosomes. We're going to be focusing on the X chromosome, which can be found in men and women. Now, the Fragile X chromosome, as I mentioned, has a fragile site at the tip of the X chromosome, and this is caused by a CGG triplet repeat, which causes expansion of the DNA at the tip of the Q segment of one of the X chromosomes. I'm going to be going into this in more detail. And here's just a graphic representation of that chromosome picture that we saw before, showing the gap at the tip of the X chromosome in the person with Fragile X syndrome. And this is caused by a mutated FMR1 gene. And just to give you a little bit of information about the X chromosome, Like all chromosomes, there's a P arm and a Q arm. The P arm is the short arm and the Q arm is the long arm. And the nomenclature is developed in this way. It starts with the name of the chromosome. So this is X, and Q refers to the long arm. 2-7, so it's segment 2 of the X chromosome, subsegment 7, and then a sub-segment of 3. So you can see that this is going to be down at the bottom of the X chromosome. A 2-7 would be at the bottom. And you can see that where the yellow arrow is, or roughly where it's located. So so you're familiar with this nomenclature, the site XQ27.3, and this is where that comes from. It's the location of the FMR1 gene, which I'm going to show you on the next slide. Okay, and at the bottom there you can see XQ27. And that is broken down into what genes are actually, or I should say what genes have been identified so far in that segment. And you can see the FMR1 gene with the blue arrow. There's also an FMR2 gene, which has a similar type of phenotype. Okay, a little bit on molecular genetics. I mentioned CGG repeats. I'm going to try to describe what that refers to. It refers to a repeat of nucleotides, and a nucleotide shown on the left is a combination of a 5-carbon sugar. It's usually ribose. So you have ribonucleic acid, or if that is has a different hydroxy group, it would be deoxy ribose, or DNA. But it has the ribose usually, and a nitrogen base, which I'll get into in a minute, and a phosphate. And that's the basic structure of a nucleotide. And depending upon which bases are attached, these nucleotides have different names. So the names of the bases are adenine, guanine, thymine, and cytosine, and they lead to the formation of nucleosides, which are adenosine, guanosine, thymidine, and cytidine. And if the nucleoside has a phosphate attached to it, that becomes a nucleotide. And this is just some more detailed information about what I was saying before, that the Fragile X syndrome is a triplet or codon repeat disease, and the 3 nucleotides that are involved are cytidine, guanosine, and guanosine. So it's CGG. Normally, the Fragile X, I should say the Fragile X site, that repeat is punctuated by adenosine, guanosine, guanosine. So normally you have CGGs alternating with AGGs, but for some reason there's no AGGs causing the interruption of that sequence, so you get a proliferation of the CGGs. Huntington's disease is another type of triplet repeat disease involving the 4th chromosome. So this is a category of genetic illnesses. So Fragile X syndrome is a triplet repeat disease. In normal individuals, the FMR1 gene contains 5 to 44 repeats of the CGG triplet. The premutation is contains 55 to 200 CGG repeats, but a full mutation has over 200 repeats of the CGG triplet, and there's an absence of the normal AGG interruptions. So in these individuals with a triplet repeat expansion greater than 200, there's methylation of the CGG repeat expansion and the FMR1 promoter gene, which is kind of like an imprinting center, and this leads to silencing of the FMR1 gene and a lack of its product, which is the FMR1 protein designated as FMRP. So what happens is proliferation of the CGG and then methylation of those codons, and especially the FMR1 promoter gene becomes methylated. It cannot produce the FMR1 protein, which is the important cause of Fragile X syndrome, the deficiency of the FMR1 protein. Fragile X premutations, as I mentioned, they have 55 to 200 CGG repeats and can be carried in both males and females. And a full mutation is greater than 200 CGG repeats. In male carriers, the premutation usually does not expand to a full mutation when passed on to daughters. And I want to point out that a male carrier can never pass on the Fragile X gene to his sons, since males only pass their Y chromosomes to their sons. They do not pass the X chromosomes. A female carrier of a premutation is at increased risk of passing on a larger full expansion version of the mutation to her children, whether they're male or female. And half the sons and half the daughters are at risk for receiving a full expansion. FMRP, that's the FMR protein, is found throughout the body. Its highest concentrations are within the brain, testes, and ovaries. In the brain, FMRP binds to messenger RNA and facilitates its transportation to neuronal ribosomes. So lack of this messenger RNA in dendrites leads to abnormal dendritic spines, which are required to increase contact with the axons of other neurons. This also leads to impaired neuroplasticity of dendrite receptors. Abnormalities in the formation and function of synapses and subsequent abnormal development of neural circuits results in abnormal development of memory and learning. FMRP has been implicated in several signaling pathways that are being targeted by a number of drugs undergoing clinical trials. So there actually may be treatments, drug treatments for Fragile X syndrome, which we'll see on the market in the future. I want to point out the metabotropic type of glutamate receptor, the mGlu-R receptor pathway, is an important target of investigation now. And just to take a second and describe the difference between metabotropic and ionotropic receptors. The ionotropic receptors are the typical receptor for a neurotransmitter which allows fluctuation of ions, sodium, potassium, calcium, and chloride, through channels. These channels open up in response to the neurotransmitter. But with metabotropic receptors, there is no channel that opens up. Actually, what happens is a second messenger, or G protein, is formed, and this leads to development of other cellular machinery that ultimately affects the transport of ions. But it's more of an indirect process, and it takes a long time. So this is the subject of a lot of investigation now, these metabotropic receptors. And the lack of FMRP represses messenger RNA production. And then the FMRP is not produced adequately, and this leads to exaggerated long-term depression of brain activity. So deficiency of the FMR protein will lead to depression of activation of brain activity. And this FMRP also appears to affect dopamine pathways in the prefrontal cortex, and this can be associated with attention deficit hyperactivity, impulse control problems, which are known to be associated with Fragile X syndrome. The downregulation of GABA pathways. GABA is a major inhibitory neurotransmitter. Glutamic acid is a major stimulatory neurotransmitter. But these all may be factors in anxiety, learning, and memory, which are commonly seen in Fragile X syndrome. And here's just a simple graphic to try to put this all together. This is a great oversimplification, just to point out that looking over on the left-hand side, you see glutamic acid, which is a neurotransmitter coming from the axon from another nerve, interacts with the mGlu-R receptor, which is a metabotropic receptor, and you need the FMRP, the protein, interacting with messenger RNA and the cytoplasm on the ribosomes to activate that receptor and lead to the change of local cellular environment. And this is felt to promote responsiveness of the cell to local cellular environment. It's a way that the brain can respond to environmental changes, and this may create improved plasticity or responsiveness of the dendrite to various conditions. So it's an entirely different system to be compared with the ionotropic type of receptor, which is immediate, and blockers of it will get an immediate effect, but drugs that affect the metabotropic pathway, you may see no effect initially, but after a few weeks or a month you start to see real changes, because it takes time for these metabolic changes to occur, and the FMRP plays an important role in that process. And here's a comparison of brain activity in red of someone with normal function versus Fragile X. In blue below, you can see that the brain was stimulated by a learning task, and you can see the red activation occurring normally, but with Fragile X, because of deficiency of the FMRP, the brain cannot be activated normally by the cognitive task that the people have to do. Okay, a little bit about clinical management. People with Fragile X are known to have behavior problems. Not all people with Fragile X. Of course, it depends upon the size of the mutation, deficiency of the protein, a number of factors. But these are 10 behavioral problems that you may encounter in someone with Fragile X: anxiety, aggression, self-injurious behavior, irritability, mania, attention problems, hyperactivity, perseverative and stereotypical behaviors, repetitive motor or sensory activities, sleep problems are all seen. commonly in people with Fragile X syndrome and may require treatment. Drugs that are used for behavior problems are SSRI category of antidepressants. Alexa is commonly used. Antipsychotics such as Abilify and Risperdal. Actually, there's FDA approval to use Abilify and Risperdal in autism, the behavior problems of autism, the aggressive behaviors that you may see. And there seems to be some relationship between Fragile X and autistic type of symptoms. So this may be one type of autism. Also the mood stabilizers such as Depakote, Tegretol, lithium can be used. Seizures are more likely to occur in someone with Fragile X syndrome, but they follow a typical pattern of what's called BFEC, which is benign focal epilepsy of childhood. And the people with Fragile X will experience this in childhood, and they usually outgrow it in adulthood. And it's pretty easily managed with the typical anti-epileptic medication. But some people with Fragile X, it can be more significant problems. But physicians need to be aware that people with Fragile X may require seizure medication. Okay, just to mention about the Fragile X associated tremor ataxia syndrome. This occurs in Fragile X carriers. This is not people with the Fragile X syndrome, and the mechanism is a little different from simply a deficiency of the FMR1 protein. It's not quite clear exactly what causes this, but it resembles Parkinson's disease and is seen in approximately half of the male carriers over the age of 70. It's not as common in female carriers because females have another X chromosome that provides whatever's needed to prevent the syndrome. But typically the onset of tremor occurs in the sixth decade of life with a subsequent progression to ataxia and gradual cognitive decline. The Fragile X associated primary ovarian insufficiency syndrome it occurs in about 20% of women who are carriers for Fragile X premutation. And the number of CGG repeats correlates with the penetrance in the age of onset of this condition, but premature menopause is more common in premutation carriers than in women with the full mutation, because just as with the tremor ataxia syndrome, it's not the FMR protein that's causing this. It has to do with a messenger RNA problem, and you can see like clumps of RNA, and there's something that has to do with the FMR1 gene messenger RNA. So it's not exactly clear what causes this syndrome, but you can also have a milder type of Fragile X syndrome along with this. Still we need more studies of this problem and what to do about it. But it's important to be aware that ovarian insufficiency can occur in the carriers, just like Fragile X associated tremor ataxia syndrome. These are conditions that have only been appreciated for the last 20 years or so. There may be other conditions that will appear associated with Fragile X syndrome. Okay, lastly, because of the use of psychotropic medications, the hypotonia, possible seizure problems, there may be polypharmacy and hypogonadism. This can lead to osteoporosis and increased risk for fracture. So the treating physician probably should consider fracture risk and their workup of someone with Fragile X syndrome. Okay, that pretty much concludes the talk. If you have any questions, send them to me at ifcd.pmay@gmail.com. Please visit our website at www.chronicdisabilities.org. That's the International Foundation for Chronic Disabilities. Once again, thank you for listening, and stay tuned for more presentations on people with chronic neurodisabilities. Bye-bye.